So what are the investigations that I would like to do for the patient? First, I need to establish three things: whether the problem is with the production, whether the normal tear film is being produced, the secretion is normal. The second is whether it is a stable tear film, whether the quality of the tear film is good, and the third is whether the ocular surface is intact. So to determine whether the secretion is normal, I should do a Schirmer's test or a fluorescence clearance or tear osmolarity. So these are the three tests that will help me talk about help me identify if the production is normal. Stability is tear breakup time, and ocular surfaces using corneal stains or impression cytology. So we will just see how we do each. Staining pattern is also very important. So when we apply fluorescent stain, the stain can take on certain patterns. So this is the eyelid. This is the palpebral fissure. So if it's predominantly in the interpalpebral fissure area, you know that it's because of aqueous. The commonest cause is aqueous tear deficiency. That's the common cause of interpalpebral staining pattern. As against, if you have a staining pattern which is predominantly present in the superior part of the conjunctiva, it is called, this is the staining pattern. So this is called superior keratoconjunctivitis, and inferior is when you have a staining pattern present inferiorly. So this is a feature of blepharitis, or it can occur in exposure keratopathy. So, but today's of interest in today's class is the interpalpebral distribution, which is classical of aqueous tear deficiency. So whenever we stain, we need to look for this area. Interpalpebral is aqueous tear deficiency, the superior limbic keratoconjunctivitis, and inferior is blepharitis or exposure keratitis. Now, tear film, all these are very important because these are simple tests that you can do in the OPD and identify a lot of signs. The next is called tear film breakup time. So, tear film breakup time can be abnormal in aqueous tear deficiency and Meibomian gland disease. So, what really happens? First, we need to understand that the procedure. First, we use a fluorescent impregnated strip, and you apply to the eye, and you ask the patient to blink for a couple of times, and then when you examine on the slit lamp, you need to look for these dark areas that you're seeing. These are the dark areas. You can see that the fluorescent is uniformly distributed here, but in these areas there is a darkness that has developed. So by definition, a tear film breakup means that the time between the last blink and the first randomly appearing dark spot. So the time between the last blink and the first randomly appearing dark spot. So that's what you call, that's what we use as an indicator of the breakup time. Normal breakup time has to be less than 10 seconds. So anything shorter than 10 seconds is, it means that there's a problem. The tear film is not holding stable enough to spread on the surface evenly. The next test to indicate production, a very, very useful, frequently done test, is called the Schirmer test. Schirmer's test is done with number 41 Whatman filter paper. It is about 5 millimeter wide and 35 millimeter in length. So this Whatman filter paper is bent at, this is a Whatman filter paper. So you bend it at 5 millimeters and you place it in the patient's eye, usually at the lateral junction between the lateral third and the medial 2/3. Around this area you need to keep the Schirmer's strip, and when you keep the Schirmer's strip here, you watch out. After 10 minutes you have to take it out, and if after 5 minutes when you take it out, if the wetting is less than 10 millimeter, again you know that there is dry eye. So this is how we read it off. At the end of 5 minutes, you can see that wetting has not reached 10 millimeters, so that is definitely indicative of dry eye. So the stains, like I told you, the dry eye examination is not complete without two things. One is examination of the lid, the other is examination of the ocular surface. So for the examination of the ocular surface, we need to stain the eye and watch. So the three stains that are used are sodium fluorescent, rose bengal, and lissamine green. We need to know a little bit of this about the stains. Sodium fluorescent, it is available as a 2% solution, or you can use it as impregnated fluorescent strips. And these strips are more commonly used because if the solution gets contaminated with Pseudomonas, which is quite a dangerous agent, it can be catastrophic because we can result in corneal ulcers, and then Pseudomonas ulcers are very, very dangerous. So most of the time we use these impregnated strips, which is about these impregnated strips can be used and disposed, and they will show us the amount of epithelial breakdown, whereas rose bengal will stain dead and devitalized tissue. Sodium fluorescent will show areas of epithelial breakdown. Rose bengal will show us epithelial tissue that is dead and devitalized, and it will also show us mucus disruption. Lissamine green also does the same things. But the advantage with lissamine green over rose bengal is that rose bengal is known to produce a lot of stinging and irritation. It is also known to cause toxicity to the corneal epithelium, and hence lissamine green is preferred. Lissamine green and rose bengal are available as 1% strips. So this lissamine green, when it's used along with fluorescent, can give us a lot of inflammation. Rose bengal is not so much preferred.